All right, without further ado, patient-centered care, Ricardo Padilla, DDS, medication-related osteonecrosis of the jaws. And we've got some great information if you want to take the time to go over that. But I want to let you know some highlights. Dr. Padilla is residency director of the UNC Oral and Maxillofacial Pathology residency since 2006, has cared for patients jointly with Dr. Blakely, an oral and maxillofacial surgeon, every Thursday afternoon since 2002, so 22 years, served as the examiner and chair of the AAOMP Fellowship Examination Committee for 5 years, was named Distinguished Alum of his dental school, Universidad Francisco Marroquin, and is a director of the American Board of Oral and Maxillofacial Pathology and will preside in 2030. So congratulations in advance. Dr. Padilla, welcome. We're so glad to have you here today.
Thank you, Tim. I'm having a little trouble hearing your voice. I don't know if everyone else is having the same problem. You started very loud and then you kind of faded away. I could barely hear your voice by the end of it. So I raised all my volume as much as I can. Can you double check for me? Can you hear me?
We will.
Okay.
Thank you for letting us know. So I'm hearing from my colleagues that they're not. Let's see. We had somebody else.
Okay,
Let me
so
try.
somebody in the chat says that they can hear us both fine. I'm going to assume that it's my speakers here that are the problem. So I'm going to just go ahead and talk.
Okay, now you're coming across a little quietly for me too, which wasn't the case before. Let me just ask my colleagues, John and Andrew, are you able to hear Dr. Padilla as clearly as you were earlier? And I'm just looking. I'm getting a message that they believe so. Yes. Dr. Padilla, if you want, I want you to be able to hear everything. So if you want, we can make a
You just
couple
came
of
back.
quick.
I don't know what happened, but I can hear you now, Tim.
Oh, good. All right. Sounds like everything's working. So glad to hear it. And so, Dr. Padilla, what's something we should know about you outside of your professional background?
Outside of my professional background is that I have always been interested in coffee and tea and barley-based liquors. Currently, I'm studying a lot about bourbon, and I am now getting quite a collection of bourbons and learning a lot about that. So it's been quite fun to know about that.
That sounds like that could be a lot of fun. Thank you so much for sharing that. All right. Well, I mentioned poll everywhere earlier. The first question, medication related osteonecrosis of the jaw is a severe adverse drug reaction consisting of progressive bone destruction and in the maxillofacial region of patients. So this is a true false. While our participants are answering that, I'll go ahead and flash up our disclosures. And now let's take a look. So again, medication-related osteonecrosis of the jaw, referred to as MRONJ, is a severe adverse reaction consisting of progressive bone destruction in the maxillofacial region of patients. And we're trending heavily on one side, Dr. Padilla. All 100% of our audience is saying true. How are they doing?
They're doing great, Tim.
Good, good. Well, I'm going to turn this over to you. Medication-related osteonecrosis of the jaws with Dr. Padilla. All yours.
Thank you. Thank you, everybody. And I am honored to be able to share this information with all of you. I know that we have a diverse audience that includes health providers of all fields, oncology people, nursing specialists, dental specialists, all kinds of health-related people. So I'm very glad to be able to share this with you. And let me see, here we go. I have one more poll everywhere to start the whole thing. I would like for everyone to please enter any condition that you may use bisphosphonates or osteoporosis for. It can be a single word, it can be a phrase. I want to see what is most of the people in the audience using it for. So I hear osteoporosis, metastatic disease, hypercalcemia, prophylaxis, malignancy, osteopenia. So as you can imagine, there are millions of prescriptions of bisphosphonates and denosumab preparations every year in the United States and worldwide. The vast majority are for prophylaxis or for osteopenia or osteoporosis to prevent the skeletal events that change the lifestyle of people that have hip fractures, etc. So I'm going to use this word cloud to focus my emphasis on this, but I know that there's people here that use it for osteopenia, osteoporosis, for metastatic disease, and hypercalcemia. I'm going to assume that it's hypercalcemia of malignancy, but we're going to also cover briefly some of the non-bisphosphonate medications and non-denosumab medications that might be used for other things, potentially giving patients a slightly higher risk of osteonecrosis of the jaw. So here is a person that has an exposed portion of the mandible. This is a patient that we shared, Dr. George Blakey and myself, and most of the photos that you're going to see come from his clinic and our joint clinic on Thursday afternoons. Dr. Blakey and his residents and myself and my residents, so the oral maxillofacial surgery team and the oral maxillofacial pathology team, see patients jointly, and we come from two perspectives, the clinical surgical approach and the more medical approach, and we have found that this is a very rich learning environment. Our trainees, of whom I am very proud of, have learned and been exposed to this. But there is a formal definition of osteonecrosis of the jaw secondary to medications, because we don't want for people to confuse osteoradionecrosis, which is secondary to radiation to the head and neck. And there's also necrosis of the jaw secondary to osteomyelitis due to odontogenic infections, et cetera, or sepsis. So the arrow is pointing at a fragment of a piece of the mandible that ultimately Dr. Blakey was able to remove and help this patient with a cure. But at the tip of the arrow, there is pus in that pool of area. It's pus mixed with saliva and oral secretions. And that is an indication that there's some sort of suppuration, most likely related to an infectious process, most of the times with bacteria. So I want to use this definition of the American Association of Oral and Maxillofacial Surgeons, which is three points. One is current or previous treatment with anti-resorptive therapy alone or in combination with immunomodulators or anti-angiogenic meds. That's one component of the triad. The second component is the presence of exposed bone or bone that can be probed through an intraoral or extraoral fistula in the maxillofacial region that has persisted for more than 8 weeks. And the third component of the trial is no history of radiation therapy to the jaws or metastatic disease in that area, because people that have metastases to the mandible or maxilla, they could have necrosis of that bone secondary to their cancer, and that will induce exposure of the bone. That is not MRONJ or medication osteonecrosis of the jaw. So this is the paper that if you would like a very comprehensive, thorough, and practical reference, this is the position paper of the American Academy of Oral and Maxillofacial Surgery on medication-related osteonecrosis of the jaw. This is their third iteration. There is a group of experts that writes these. They are people that have extremely high exposure to patients with denosumab. They also go through a very comprehensive scientific way of putting out the information. And Andrew, I believe we have a link somewhere to this paper. This is an open source resource from the AMOS, and they will have that for you. It was published in 2022, but it is current up until now. And they have reviewed this multiple times, and it will most likely be revised. But here is another quick little question. Which of the following patient populations can benefit from having an oral or dental evaluation prior to starting treatment? And I'm referring myself here to treatment with either a bisphosphonate or a denosumab preparation. So I want to hear what our audience thinks. And in the interest of time, I'm going to stop it here. So about half the people are choosing A, about 30% of the people D and C, and some people B. The reality is that this is a tricky question because all of these populations could benefit from having an oral and dental evaluation prior to starting any of these treatments. As you can imagine, all of these people are going to have significant iatrogenic injury or potential injury or immunosuppression to their system. And if there is any type of bacteremia in their oral or maxillofacial area, they could have serious problems with that. So visiting their dental home prior to the onset of any of these, and for our purpose today, for any denosumab treatment or for any bisphosphonate treatment, it will be very beneficial for them to have a clearance by their dental office. The dental office includes a dentist, a dental hygienist, a dental assistant, a dental therapist, or any combination of them, almost always including a dentist, of course. But it includes a thorough medical history taking, radiographic examination with either a panoramic radiograph or a cone beam CT or whatever radiographic or imaging study that the dentist feels is appropriate to prescribe. And also a clinical evaluation that includes looking at the entire oral mucosa, oropharynx, and doing a palpation of the head and neck, including the neck. That also involves asking these patients about issues. But if somebody fulfills the definition of medication-related osteonecrosis of the jaw, the next step in managing this patient will be to put them in the right staging or classify them in the category that they belong. At risk category is somebody that has no symptoms and no exposed bone, but who has been exposed to any of these medications. So we call them at risk category. And then there's stages 0, 1, 2, and 3. And so stage 0 is equal to the at risk, but now they have type of symptom, most of the time some kind of pain in the jaw area that cannot be associated with an odontogenic source. For example, a bad tooth or an infected tooth or periodontal disease. Stage 1 is somebody that has already exposed bone, that has been exposed for at least 8 weeks. And when that exposed bone first appears into the mouth, when the gum retracts from that area, it usually is still half alive and it will be sore and painful. Once it becomes necrotic, that piece of bone doesn't hurt, but the patient might still have some source of infection or suppuration or a fistula that you can see the production of suppuration or pus from that area, especially after palpation of that location. These people don't have active infection, so that will be a stage 1 person. Then we have stage 2, and a stage 2 person is somebody with exposed and necrotic bone or a fistula that probes to the bone with evidence of infection or inflammation. And these people usually are symptomatic, and they also will have some radiographic changes. Radiographic changes in patients are usually a late issue that we don't find initially when they are in the dense bone formation. Occasionally, if there is inflammation before, we will see a little rarefaction of that area of the bone, but we don't see a, quote, loss of bone until at least 30% of the mineralized content of the bone is lost. So it takes about that long for that area to show radiolucencies or bone loss radiographically. And then stage 3 is somebody that has exposed and necrotic bone and a fistula that probes to the bone with evidence of infection and one of more of the following 5 points. Exposed necrotic bone extending beyond the alveolar bone. So the alveolar bone is the area of the mandible or maxilla that goes from the crest of the bone next to the crown of the tooth to the tip of the root. That bone, called alveolar bone, only exists if there are teeth. Once somebody loses a tooth, the alveolar bone slowly disappears, and people are left only with their basal bone. So that will be the difference. If it goes into the basal area of the bone, past the root tips, then that will be checked for bullet number 1. Second bullet is a pathologic fracture, or an extraoral fistula will be the third, and an oral nasal communication, or loss of bone extending past the inferior border of the mandible or into the sinus floor. So this will be a stage 3 person. So they build up on each other. Importantly, the classification is important because, as you'll see down the line in an algorithm that Amos offers in the paper, you can fit that person into specific stage, and then there's suggestions of management for those people. The stages in a patient can change. So somebody might be on stage 2 or 3, and after some management, they may go back to stage 1, or they may get worse and go back to stage 3 or 4. I'm sorry, 2 or 3. So it is a thing that has to be staged at every examination to make sure that they are current on their classification. So here's somebody with medication-related osteonecrosis of the jaw. This will be somebody with an early stage. In this case, this is somebody with stage 1. So there's exposed bone. It's been there for more than 2 months. Also, there is history of exposure to the medication and no history of radiation to this area. And in this case, I'm showing you somebody on a higher stage. This is somebody that already has this, who is symptomatic, in whom there is a little bit of signs of infection, their suppuration. But more importantly, these patients with exposed jaw bones, many times their chief complaint is that they are going to feel that the shards of edges of bone that are very sharp will be cutting on their tongue, or they will be cutting on their cheeks, or they will be sensitive to them in some way. So sometimes filing of these edges of the bone is very beneficial for symptom relief or for preventing further ulcerations of the soft tissues adjacent to those areas. Not something that is recommended to be done by a non-dental provider. You don't want to be doing this without the proper armamentarium in the proper setting. So that's that part. And then let me show you somebody else that intraorally has also fulfilled the diagnostic criteria of medication-related osteonecrosis of the jaw. This is a mirror photo. So here's a mirror, and this is the inside or the lingual portion of a lower cuspid or a lower canine on this patient. And this yellow hard material is actually a portion of this patient's mandible. The lingual cortex of the mandible is covered by mucosa that in some areas is very thin, especially in the more posterior area. So on the inside portion of the back lower molars is where the mucosa is thinnest, and any injury in that area will have a slightly higher incidence of having that problem. Now, let me show you this patient. This patient is a patient on stage 3 osteonecrosis of the jaw, not because the intraoral component, but because there is a corresponding extraoral fistula that was suppurating out following the path of least resistance, in this case, percolating through the tissue planes and finding its way outwardly. So this is somebody that fulfills the diagnostic criteria for stage 3 osteonecrosis of the jaw. This is a panoramic radiograph of somebody's maxillofacial area. And so a panoramic radiograph is the one that the patient goes and walks into a machine or sits in front of a machine. They bite on a little stabilizing bite mark, and then they are stabilized with some prongs, plastic prongs on the sides, and the machine goes around them. It feels like they are having a CT, which is technically similar in that. This patient has osteonecrosis of the jaw, and here on the mandible, where the blue arrow is pointing out, this patient suffered a pathologic fracture of that mandible. So at this point, there is lack of continuity between one portion and the other of the mandible. And this is an area that started with necrosis of the jaw. The process in this patient is something that I would like to cover because it's not a rare occurrence when somebody doesn't see a dentist and takes care of their oral issues before treatment. So for that, I'm going to refer you to the white arrow area. These things here that you might be able to see on your screens are pieces of teeth that have been carious and broken down and are just left with the root tips that are stuck in the little bit of alveolar bone that this patient has left. The rest of the tooth has been destroyed by cavities or fracture or whatever. And then there is communication between the mouth environment and the jaws. If you think back at the biofilm that occurs in the oral cavity, it's a very rich, diverse biofilm, and there is all kinds of organisms, but they will eventually percolate through the tooth or around the tooth into the bone. This bone area here is designed and is supposed to be a sterile environment. And in normal, healthy patients who have not been exposed to bisphosphonates or to denosumab, then the vascularity in these areas and the immune response and the inflammatory response is adequate. So most of the times, they will be able to fight off the inflammation or infection and produce healing. If there is anything that prevents them from doing that, then that bone is going to have osteomyelitis. And if that is not stopped with medications or with procedures or by the patient's inflammatory or immune response, then that osteomyelitis will progress and it ends up with cellulitis, bacteria, sepsis, etc. So these two teeth is exactly how there were here a tooth in here that was broken down. It got into that area of the mandible. The bacteria got into that area of the mandible, produced an infection, and in a patient with any of these medications, the healing ability of the bone is severely compromised and they don't heal well or not at all. And then they have necrosis of that area of the bone. And as you also remember from basic sciences, the gum tissue doesn't live very well on top of dead bone. It requires some of the vascularity from that area, plus it doesn't like the bacteria coming from underneath. So ultimately, most of the times these areas ulcerate, either because the epithelium and the mucosa die, or because there is a fistula that opens that area of infection of the bone into the mouth, and that becomes now a bigger hole that snowballs into a much larger area of exposed bone. And if you go in here to the next question, we'll ask you, all patients who are on bisphosphonate or denosumab treatment should be asked about oral symptoms and have an intraoral examination at every appointment. So this is the patient that you will see that you may have put on Prolia, or you may have prescribed Exgiva, or maybe zoledronic acid, or maybe Fosamax, for example. I'm using just examples of all of these medications. And the answer is absolutely true, because this is retrospectively how we could have found out patients or found patients in stages at risk 0 or 1, wherein we could do a lot more to prevent further damage. And a lot of the patients that we find now are in stages 2 and 3 that only are aware of it because they are now infected and they have symptoms. So the answer is absolutely yes. We would like for everybody who is on these medications to be screened at least verbally, and ideally verbally and clinically by means of an intraoral examination at every appointment possible. Now, an oral examination is something that for dental people is a natural thing. That's what we do all day, and we do it very expeditiously. But somebody who is not in the dental field might benefit from me using a little bit of time to remind you that what we need to do is to the objective of an oral screening or oral mucosa screening and jaw screening and maxillofacial and head and neck exam is to look and feel all the areas of the oral mucosa and oropharynx that you can, except the soft palate. You don't want to touch that. You don't want to touch the tonsils or the uvula because of the gag reflex, but you want to visually examine everything that is within eyesight of yourself when somebody opens their mouth very wide. To do that and to accomplish that effectively, you need light. There is no way that somebody can do an intraoral examination without an alternate source of light. It can either be your cell phone or a flashlight, or maybe you have a clinical scenario in which you can direct some light into somebody's mouth. The other thing that you need for doing an intraoral examination is a tongue blade. If you're not in a dental office, you will need a tongue blade to move the tongue around and especially look for lesions of exposed bone or areas that look abnormal. If it doesn't look like a tooth, or if it's not coral pink mucosa, then that area doesn't quite look normal, and you might need to take a good look at that area and ask that patient. The other thing that's important is to ask these people if they have had any issues with mouth pain, any bleeding that's spontaneous, any discomfort, any numbness, or any sharp edges that are unusual for them. Also important is that when you do an intraoral examination, you have to ask that person if they are wearing any denture or partial denture, because we have to look at the mucosa underneath the denture. So these people will have to take their dentures out, put them in a little napkin and hold them in their hand and not let go while you do the exam. And after that, they can put it back in. If for any reason that is not achievable in your setting, then it is okay for you to ask that person to go see their dental health provider and have them do that examination for them. So you need light, you need something to push the tongue and the cheeks around so you can see in a direct line of vision, and you need to have all of these people, if they are wearing dentures or any type of oral device, to remove it so you can see underneath that. And that's going to be important in a moment when I show you some of the cases that I want to share from Dr. Blakey's and my experience, because many times this starts with a dental extraction, or this starts with a tooth infection, or this starts with a denture that doesn't fit or that rocks. So let me show you this patient. This is somebody that was on denosumab, secondary to management of metastatic breast cancer. And this person has pretty much the entire alveolar bone of the mandible exposed. Dr. Blakey was able to help this patient a lot with symptomatic relief and sequestrectomies. But this is somebody that wore a denture. That denture, if you are not in dentistry, then you'll know that the denture is a piece of plastic that doesn't change, yet the bone of the mandible and the maxilla and the mucosa do change. So after some time, the denture doesn't quite fit perfectly. And then it starts to have a pivot point, and it moves and it rocks and it slides. These pivot points where dentures rub, or areas where the denture edge cuts into the gum, are usually the areas where these people are going to have a small ulceration. And this small ulceration acts as the port of entry of bacteria from the oral environment into the sterile jaw bones and triggers this domino effect of osteonecrosis of the jaw. Sometimes it's a denture, sometimes it's an extraction, or occasionally it will be a tooth infection or periodontal disease. And that's why we are so emphatic that people that are undergoing or will go into a treatment with bisphosphonates or denosumab will absolutely benefit from visiting their dental home or establishing one if they don't have it, and having a good thorough examination of their oral head and neck that includes radiographic survey as needed, and also examination of all the areas of the mucosa. And if there are any areas that require treatment, ideally to optimize their dental health before the denosumab or bisphosphonate or whichever treatment is going to start, to try to prevent this from happening. It is a lot easier to prevent this from happening than to actually fix it once it starts. Here is a list that's provided in the paper, and then I have expanded this a little bit, and this is an ever-growing list of medications, families of medications that can be associated with medication-related osteonecrosis of the jaw. However, the papers that I read are very careful, not associating causality of the medicine to the disease. This is just a risk factor. So people that are on any of the medications on the left column have a slightly higher risk of developing osteonecrosis of the jaw if they were to have some sort of bacteremia that's otherwise would be transient. It could be catastrophic bacteremia for these people. And this list, I suspect, will continue to grow. And every time I turn around, there's a couple more papers in the literature that have medications that are associated with that. And I want to share a few of them with you. So, which of the following points are important to cover in the pre-treatment discussion with all patients who will receive bisphosphonate or denosumab treatment? There's a small chance of developing medication-related osteonecrosis of the jaw. I will examine your mouth for any obvious signs of infection, ill-fitting dentures or ulcers. If I see any infection or ulcer, we will not start the treatment until you get that taken care of. And you need to have a dental house, or if you feel any abnormal sign or symptom in your mouth, let us know or see your dentist. The reality is that everybody is kind of jockeying for position on these A, B, C, and D, and all of them are important. So this is not a testing situation that is a gotcha situation. This is a testing situation that aims to show you and to reiterate the points we're doing. All of these are important things to do or tell our people that we put on this kind of medications. So moving on to the next one, I'm going to show you a few papers in which, again, there is no causality. There is just an association of some medications and a higher incidence of developing medication-related osteonecrosis of the jaw. Most of the papers that I have seen have a combination of drugs, not only one. So, for example, this is a paper about TNF-alpha inhibitors, but many of these patients were also on a bisphosphonate or on denosumab. But the people with TNF-alpha inhibitors develop a slightly higher incidence of that. Very few of these patients developed it in the absence of the other meds. But it is the wolf in sheep's clothes. There's also this other paper that shows you some longitudinal areas with palmociclovir and denosumab. And there's also another paper here with ademaciclib that was also associated with a higher incidence of osteonecrosis of the jaw. Then there's anti-angiogenic medications that are listed here on the left that have been reported to have or to increase the risk a little bit more. They don't by themselves do it in the majority of cases that I was aware of up until the starting of the talk. So, of course, this all can change down the line, but these are some of the meds that could be associated with that. My point in showing all of these papers with different medications that have been linked to Morange is that these patients probably will benefit from having a dental screening and having their dental home do a check and a clearance, just as if they were going to have radiation to the head and neck. It is relatively simple for dental healthcare providers to do these kind of examinations. And if there is anything that can be identified that can be fixed before, in a timely fashion, before the onset of the treatment, then that should be done. I'm going to keep going. This is just more medications that are associated with higher incidence of that, with the conditions that some people use them for. And so here is a patient that was a young patient who had Crohn's disease and was using one of these medications. And this person ends up with a couple of teeth that I'm going to show here on the bottom right. So here are two molar teeth. This molar tooth that's a little bigger than the others in the photo had a big filling. And then that's a first molar tooth that usually comes into the mouth around age 6. And then on the back of it, there is a tooth that didn't quite come in. It is half in and half out. There's a little bit of gum on top of that, and it is directed into the tooth in front of it. So it is an impacted tooth or a stuck inwards tooth or halfway in. When that occurs, there is a port of entry for bacteria as the tooth is trying to come in and the gum is now broken. There's no good gasket seal here, and then there's bacteria that can come into the jawbone and create this infectious process that ends up with an infection of the jawbone that continues to drain and ends up with somebody like that. Now, this is just an example patient of some of these situations that could happen to some of these patients with osteonecrosis of the jaw. So these are, we've gone through this. So I want to show you this patient. This patient doesn't have anything wrong with them. This is somebody who has a perfectly healthy mouth, but I took a photo of this patient because this patient has something that I have and many other people have. This is called a palatal torus. It's kind of synonymous or similar to having a bunion in somebody's tooth. It is a chunk of cortical bone that grows outwardly, and it creates a protuberance of that area, usually covered by mucosa that is a little thinner than normal. And because it sticks out, you can imagine that every time that somebody with one of these is eating a potato chip or a toasted piece of bread or something that's crunchy or hard, you have a higher incidence of scratching and hurting that area, to the point that some people will develop ulcers on top of these areas. If that person was to be on any of these high-risk medications or medications that put patients at higher incidence of osteonecrosis, then that person potentially could have an issue with bronch. Let me show you somebody that has also a palatal torus, and this person has the maxillary tuberosities that are very large. So if this person was eating something hard or crunchy, they could easily have this type of problem in those areas, because these areas injure easier than, for example, the area of the soft palate right here, or some vault of the palate without any exposure. This is also a healthy patient that has these two knuckle-looking areas of bone on the lingual portion of the mandible. These are called mandibular tori. I have them myself, and I get them traumatized all the time with food particles and toast, etc. So these are the same concept. So these mandibular tori are also areas where we see patients having their beginning of osteonecrosis if they are in a high-risk category or cohort. There's also an area behind these mandibular tori in all the patients, all the people, which is called the lingual mylohyoid ridge line. And that is an area that goes on the inside cortical bone of the mandible, kind of in the molar region, that is where some muscle inserts to make the floor of the mouth. It sticks, it makes it stick out a little bit, and it acts kind of like an area where there's more trauma than normal as well. So, tora, I frequently traumatized. This is a patient with multiple myeloma that had pre-existing tori. You can see on the blue arrows that there's tori in this person. This person didn't wear a denture, couldn't possibly wear a denture because of the tori. So they were just eating soft foods, but eventually there was an injury and an ulcer. And as you can see here on the white arrow, there was a small area of ulceration in that mucosa that exposed the bone to the oral environment. Bacteria went in, and then once the bacteria were in the non-healing bone, it underwent necrosis, and this patient ends up with suppuration in that area. So this is something that frequently Dr. Blakey and I have patients with, that they are on this type of medications or procedures or exposure or high-risk cohorts and end up with this type of process. Now, here's another area that for most non-dental healthcare providers, you will not know about this, because this is a clinically asymptomatic invisible condition, but it is called florid cemento-osseous dysplasia. And in this case, the turnover of the bone is a little mismatched. So there are areas that are more fibrous, and there are areas that are more osteogenic, and therefore they will be denser. These dense areas can ultimately remain for life. And as the patient undergoes atrophy of that alveolar bone because of the lack of teeth, then those dense areas stick out like splinters from underneath the gum, and they can poke out. If that was to happen in somebody that has any of these medications in their system, they can end up with another ulceration, with bacteremia of the bone, and ultimately with something like what we see here in the red circle. So you see the blue circles, this person has multiple areas of florid osseous dysplasia. And in the red circle, there is an area of florid osseous dysplasia that had bacteremia with subsequent necrosis of the bone with sequestrum formation that required for Dr. Blakey to be able to go out there and in there and remove that. There's changes in the bone that are late, usually after months of having this problem, but the bone tries to defend itself by making itself denser, and what ends up accomplishing is that it makes itself less vascular, and therefore these people will have higher chances of having more osteonecrosis in that area. So bacteremia in hypovascular or hyperdense bone, such as benign fibroosseous lesions like the one I just showed you, the florid cementoosseous dysplasia, or tori or exostosis may result in osteomyelitis. Now we have a problem with these patients because osteomyelitis in a patient that doesn't heal well from their bone could result in osteonecrosis of the jaw. So I think here comes another case. Yeah. So this is another case that I wanted to share with you. This is somebody also in one of these medications. She wears dentures and she has this area of exposed bone. By now, you can imagine that that is exactly where her mandibular denture was pivoting. So that mandibular denture was rocking itself in there and ends up creating a tiny 1 millimeter ulcer that then it just opens into this larger area of exposed bone. And I'm going to show you, this is a photograph of her CT. This is the screen. But you see here on the other side, so this picture that I'm showing here is on this area. And on this other side, there is this gap of thing that has the same density as that air. And I'm going to show you clinically how she looked like over here. So she has exposed bone on that area as well on the left side. And this is a cotton tip applicator that I took. And as you can see, my hand is outside her mouth, and this cotton tip applicator is doing that. So in this particular case with this person, very unfortunately, she has complete necrosis of a portion of the mandible and a fistula that is chronic, that essentially created an opening that opened into her submandibular area. And you see here how she was draining saliva and oral contents onto her skin, developing this pretty significant dermatitis that was very symptomatic to her. And this is the result of somebody with stage 3 osteonecrosis of the jaw. So my point in this talk is to share with you that this is something that we would love to prevent, because in many cases we can. And if we can prevent it by having their dentures adjusted or relined or fixed or lined with something softer, or if we can have any bad teeth out of the area, then we would like to have the opportunity to prevent it or help prevent it rather than fix this problem. Now, another little piece of advice that we have that the paper, the position paper of Amos also covers, is that any little piece of bone or sequestrum in a patient who has history of cancer or active cancer, you probably want to send that in to pathology to make sure that there is not a met in it, because that could or not change their protocol of management. So here is the algorithm that the paper gives you. And if you are in dental healthcare, this is your playbook. If you are in non-dental healthcare, this is also a playbook by giving you an initial evaluation, and everybody gets an H&P, and depending on the need, you might need some imaging and the staging. Then you will follow this algorithm, and I'm going to expedite this a little bit because I'm running out of time, and I want to make sure that we complete everything. But this is on the paper, and this is the initial evaluation. But at some point, you are going to either decide if you're going to do medical management without surgery, or if you're going to do surgical management of this initial patient evaluation. If you do non-surgical management, then you're going to use the patient's stage of disease to help you decide which of these three tiers you're going to use. If you're just going to do local wound care of the exposed bone with antimicrobial rinses, which the one that we recommend is 0.12% chlorhexidine gluconate rinses for it to be switched for 1 to 2 minutes and expectorate and repeat that twice a day. This is not the usual dental recommendation for chlorhexidine, which is much shorter and 1 time a day. But in our anecdotal experience, the longer they keep the rinse in their mouth, the better it's going to work. And there is a problem with chlorhexidine gluconate that in the majority of cases, it will stain the teeth dark brown, gray, or blackish. And you know that that patient is following the instructions because their teeth are going to be darker when you see them in follow-up. If their teeth are not stained, then they probably are not using it long enough. So you follow the stage-by-stage management of that. That could include just the rinses, or if there is a sequestrum that's already mobile and you feel comfortable just taking it out like that with very gentle forceps manipulation, then you can do that. If you are not able to remove it with very gentle manipulation, that patient needs to be referred to somebody that does that on a regular basis. And the majority of people will be oral and maxillofacial surgery. And here at UNC, we have many of them. The person that does the most of this is Dr. George Blakey, is the person that I have the joint clinic with and the opportunity to follow him around on Thursday afternoons. Stage 2, as you remember, this also involves most of the times giving patients systemic antibiotics because they will have signs of infection and pain, and also pain control as needed using the usual protocol for pain management that you have at your institutions. And stage 3, most of the time, it will require surgery, and that means that it has to be completely removed, that area of necrotic bone, and make sure that the edges of that removal area are not sharp and that you have waterproof suturing to make sure that there is no more bacteremia going from the oral cavity into the sterile bone that you just found in the postoperative period. So the mandible and the maxilla use slightly different criteria for deciding the management, but they are in your paper for you to use and use as guidelines. This is the mandible, and here is the maxilla. And again, this is the reference for you to have. I believe that we are putting a link either in the chat or in the handout or in whatever email communication you'll be getting. The link is also there. Feel free to screenshot this, and you will be well equipped with a reference for you. So I want to thank you for the time to share this with you. This is something that both Dr. Blakey and I are very familiar with, unfortunately, but we would love to share this with you in order to try to prevent as many cases rather than treat people with this, because this is a life-altering problem for these patients, and it is not a very common problem, but when it happens, it's a life-altering thing for the people that get it. If anybody would like to have any offline question down the line, my email is on the screen. Otherwise, I think, Tim, this is the time that we're going to be opening up for any Q&A, but thank you.
That's right, Dr. Padilla. Thank you so much.
My
This
pleasure.
has been fascinating, and the opportunity to intervene and make a real difference in these patients' lives is very significant. While we're waiting for questions to come in, I definitely have a few. Um, One of them, let's see, I wrote down several actually. What are are there average waiting periods that you're looking at? So let's say the dentist identifies an issue and that issue needs to be addressed. And then what sort of period are we waiting before treatment with one of these medications could take place? And then similarly, is there a point at which, after the medication has been concluded, at which you can say, okay, now it's safe to maybe have a dental procedure that was postponed, that sort of thing.
Great. That is covered in the paper, in the
Okay.
position paper, but I'm going to try to summarize some of that. So in general, the guidelines is similar to the radiation protocol. So usually if somebody is going to have a tooth extracted, the healing time is between 2 and 3 weeks for an ideal scenario, because you want for epithelium to cover the extraction site completely to be
Mhm.
sealed, sealing the jaw bone from the mouth. So 3 weeks is usually about the sweet spot for that. If for whatever reason that is not an option, then the longer the better, but ideally that's the case. Sometimes we don't extract the teeth that these people have if they already started the medicine. There is a very interesting phenomena that occurs in teeth. So teeth are set in the location where they are by means of locking themselves and biting against the upper or lower tooth corresponding to it. And if there is a gap between because you lost a tooth or something happens to that tooth, then that tooth is going to spontaneously migrate outward until it touches again. So what
Mhm.
we have asked sometimes in some of these patients when the finances are permissible and when there is that enough time, we will have an endodontist do a root canal treatment on the tooth that's a problem. And
Mhm.
then we will have that person or their dentist grind down or decapitate the tooth. So there's going to be just a little bit of the crown out, and that's going to make that tooth come outward or, quote, over erupt until it touches again. Once it touches, we decapitate a little bit more of the tooth, and it will work itself out of the area, having a gasket of periodontal ligament sealing that area without the bacteremia that we will have, not requiring an extraction, but letting that natural phenomena occur with much less chances of having that problem. So that's one of those areas. Now, how about the possibility of somebody on the medications having completed their treatment? When can they have dental treatment or dental alveolar processes?
Right.
That is depending on the medication, because the half-life
Mhm.
of, for example, zoledronic acid is measured in decades. It incorporates itself into the hydroxyapatite of the bone. And so as soon as an osteoclast decides to become back alive and destroy or resorb a little bit of the bone matrix, the bisphosphonates is going to be captured by the osteoblast next door and repositioned back into the hydroxyapatite that makes the matrix again. So it recycles itself locally, and the half-life is very long. So the effects of especially nitrogen-containing IV bisphosphonates is pretty much lifelong. As
That.
opposed to, for
Mhm.
example, denosumab. Denosumab is the rancoligand inhibitor, and then that medication acts in an extracellular compartment. So as soon as you withdraw you discontinue the use, the serum levels of denosumab start going down, and that will allow for first better healing chances of that area and less risk as they continue progressing. So it depends on the half-life of the medication. Some of them is lifelong, and some of them is a few months.
Interesting. And of course,
Mhm.
that opens up more questions, but I want to
Oh
get
yeah.
to some of the questions of our participants. So, first one, can osteonecrosis occur in the DMJ area?
Personally, I have not seen osteonecrosis in the TMJ area, conceptually, it will be a lot harder to happen, but if there is any chance of bacteremia to that area, it could. Now, there are cases that are reported in which there is no history of trauma, no history of ulcer, and no history or any documentation of bacteremia, and the patient still develops osteonecrosis of the jaw. Those are very few cases. Most of the times, we hypothesize that the patient may not remember, or the injury was of short time, that the mucosa healed over, but the bacteremia already occurred. But I have not seen TMJ, osteonecrosis of the jaw, secondary to medications. I'm sure that if we search the literature, there'll be a couple, but I have not personally seen one yet.
Gotcha. Thank you so much. And there may be a little typo in here. As a preventative measure, should asymptomatic tori be reduced in case of future medical issues occur? Yeah. Okay.
So that's a very important question. And right now, the recommendation is no. I don't think that the amount of people that have tori need to have their tori removed before denosumab or any of these areas. So we don't do that. But what we do is we educate these people that because they have tori or exostosis, they have a higher incidence of having this problem. And if they were to develop any or have any injury on their torus or tori or exostosis, that they need to start rinsing with salty water rinses 3 times a day and come to their dental home immediately for an evaluation. And if there is an ulcer, we will transition them to chlorhexidine gluconate and with a very close follow-up until hopefully that heals. In addition, we will put them on a soft diet and minimal trauma to that area. And if it heals, we aborted the problem. If it doesn't, then we will catch them at stage 1. But we don't recommend currently that everybody that has a torus goes and gets that removed.
Thank you. And the question was perfect. I misread it initially, so that's great. Another question, and this led to another one of the questions, and I've got a pile of them. We won't get to them all, but in terms of balancing the decision making between these risks and other factors. Here our audience member says, I have a friend who has osteoporosis and long issues since childhood with jaw issues. Not sure specifically she is in need of IV bisphosphonate, but is frightened due to history, risk of fracture versus risk of osteonecrosis. Any advice?
So this is where statistics are sometimes useful, because the risk of somebody developing osteonecrosis of the jaw secondary to a medication is relatively low. It is, in cases of oral bisphosphonates, for example, alendronate, it is in the less than 0.1%. In cases of IV bisphosphonates or denosumab on a monthly basis for malignancy, then it goes to, there's reports up to 7%. In our experience is much less than that. So let's say that it is rare. And the more important thing that we always have this conversation with these patients, and most of the patients we see is after they already have had the exposure, is they ask us, should I have taken this medication? And the answer is always yes, because the medications are excellent for what they are designed. They prevent many hip fractures. They control hypercalcemia. They help with the skeletal events of metastatic disease. So people should take it if they have indication for that. They're great for what they were designed to do. And then they will have a risk of having this problem, which can be minimized by having periodic oral examinations and elimination of any foci of infection. The tricky part is in the person that has, for example, osteopenia, and their DEXA scan is kind of borderline, and they cannot tolerate oral bisphosphonates, so they may want to use an IV nitrogen-containing bisphosphonate. That person will have much higher risk of having this osteonecrosis of the jaw. But the bottom line is, if somebody needs, for a reasonable medical reason to take any of these medications, they should. And with proper education and preventive measures and surveillance and early intervention, we can either prevent or abort or decrease the extent of their disease as much as we can.
Great, thank you. And of course, with any patient-specific question, we have to say that of course the patient, in this case the friend, it needs to meet with their healthcare provider and their dentist. Yeah.
Absolutely. Absolutely.
All right. Well, Dr. Padilla, as much as we would like to keep talking, we are past the hour, so we want to give you a heartfelt thank you. I know we've all learned a lot today, and this is incredibly important and relevant information for patients and providers. I want to say thank you to the state of North Carolina for our funding through the University Cancer Research Fund and the people of North Carolina and the UNC Lineberger Comprehensive Cancer Center. Specifically, our team, Benny Obore, John Powell, Oliver Marth, Andrew Dodgson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all that they do. Don Poe for the song at the beginning, Backroads.